evening to all of you. I'm Dr.Eidan Bilal from SKIMS Srinagar, and I'll be presenting today's journal club. Today, I'll be presenting a paper, and the topic of discussion will be what is better for post-electric burn compound defects? Should we go for early or late flap cover or reconstruction? So I'm presenting this paper entitled Early Debridement and Delayed Primary Vascularized Cover in Forearm Electrical Burns, a prospective study. This study was done in PGI Chandigarh and it was published in year 2016. The authors of this paper are Dr. Anirudh Mene, Dr. Gautam Biswas, Dr. Atul Parashar, and Dr. Anish Bhattacharya. This study aimed to explore the effectiveness of starting with early wound debridement and then providing a vascularized covering to the affected tissues in cases of electrical burns, which can prevent further progression of this pathology. Majority of the high voltage electrical burns occur at the workplace and adult age group. In children, injury is usually accidental, occurring while playing near the high voltage power supply lines. Initially, large blood vessels may appear patent, but if the endothelium was damaged, mural thrombi would form, resulting in thrombosis and distal limb ischemia. This was a prospective study which was conducted over the period of 12 months in the Department of Plastic Surgery at a tertiary level teaching hospital to include all patients of electrical forearm burns. The inclusion criteria in this study was all patients who had post-electric burn compound defects over the forearm. And those patients who had associated life-threatening injuries or who presented with obviously charred limbs at the time of presentation, they were excluded. In 1 year, it is written in the paper that 81 patients had presented with history of sustaining electrical burns. Among these, many patients who had scalp injuries, who had head injuries, spinal cord injuries, they were excluded. And among them, only 16 patients fulfilled the inclusion criteria and were included in the study. Patients presenting within 48 to 96 hours were assessed for depth of tissue involvement, both clinically and with PET findings. Those who were presenting later than 96 hours were assessed for tissue involvement during debridement. The depth of involvement was assessed mainly by identifying structures involved during debridement. Distal limb viability was assessed by examining presence or absence of distal pulsations, capillary refill time, and pulse oximetry reading compared with opposite healthy limb if it was uninjured. If there were features suggestive of compartment syndrome at the time of presentation, liberal fasciotomy was done with standard defined incisions to release the compartment pressure. And diagnosis of compartment syndrome was done by clinical examination in this study. And in this study, around 9 fasciotomies were done. Of 16 patients in the study group, only 4 patients presented within 96 hours. They were assessed with PET FDG scan for the depth of tissue involvement. Debridement was undertaken within 48 hours in 13 patients, and 3 patients were taken for debridement after 48 hours. On primary wound assessment in 2 patients, muscles were not obviously necrotic and they were reassessed before debridement. Procedure was conducted under regional or general anesthesia using tourniquet in all cases. Extent of involvement of muscles, tendons, nerves, and vessels were noted. Bleeding, color, and contractility of the muscles, along with the status of the tendons, nerves, and vessels were noted after tourniquet release also. Debridement was repeated within 2 to 4 days after daily wound assessment and need for further debridement. In this study, they have seen that an average of 2 debridements were required for the wound to be ready for the definitive cover. And interval between each debridement, it ranged from 2 to 18 days. Flap cover was planned depending upon the status of the wound. Total of 8 distant pedicled and 6 free flaps were undertaken. Clinical assessment was done for median, ulnar, and radial nerves, and touch sensation at the respective nerve territory were noted. And range of motion, both active and passive, of all joints of hand was documented. Then the loco-regional flaps, which were not available for use due to locoregional flaps were not included in the study due to the nature of the injuries. Then functional and aesthetic outcome was assessed at 6 weeks, 2 months, 3 months, and 6-month follow-up. Patients were provided with this activity of daily living chart at 3-month follow-up, and they were asked to score depending on the scale of easy to difficulty in performing the outlined tasks. They were scored as 1, when patient had no difficulty in performing the activity, 2, mild activity, mild difficulty in performing the task, 3, moderate difficulty, 4, severe difficulty, and 5, when patient was not able to do at all. Then results. Most of the injuries, around 80%, were sustained during work. 3 of them were electricians who were injured while repairing high voltage lines. 3 pediatric patients were included in the study, and they had contact burns usually with the high tension cables. All patients were right-handed, and all injuries were due to high voltage. The dominant hand was affected in 12 patients out of 16, and bilateral limbs were involved in 7 patients. 7 patients required fasciotomy. The volar forearm was involved in 14 patients, while 2 patients had involvement of hand and thumb. The hand as a whole was viable in all patients except 2 patients who had non-viable little finger, which required debridement. Patient had involvement of either median, ulnar nerve, radial nerve was not involved as injury was predominantly on the volar aspect of the forearm. 3 patients showed involvement of combined median and ulnar nerve. Involvement of only median nerve was seen in 2 patients, while only ulnar nerve was involved in 6 patients. PET scan was done in 4 patients for assessment of involvement of deeper tissues, focusing on accuracy and predictability of PET in assessing this. Then FDG uptake was adequately seen in upper third proximal muscle bellies of the volar forearm. Pronator quadratus was involved in 3 cases. That is, it showed no glucose uptake. And debridement findings in these patients correlated well with PET findings. FDP was involved in 4 patients, and FDS was injured in 3 patients. 2 patients had viable muscle post-fasciotomy, which were covered with skin graft. 14 patients were provided with vascularized cover after final debridement. 6 free flaps were performed and 8 pedicled flaps were performed. Pedicled flaps were selected in cases with recipient vessel involvement and associated proximal injury, leading to impaired venous
Sorry,
return
just
of the
1 minute,
recipient part
please.
and
Sorry, just 1
associated
minute. 1 minute.
comorbidities.
Please mute your. Somebody is still on. Chalo, you continue.
The free flaps that were performed were latissimus dorsi flap, 1 latissimus dorsi flap, 2 thoracodorsal artery perforator flaps, 1 lateral arm flap, and 2 ALT flaps. In 4 patients, ulnar artery was used as a recipient vessel, while in 2 patients, radial artery was used as a recipient vessel. 3 out of 6 free flaps were necrosed. All patients in home, 3 out of 6 flaps were necrosed, and all patients in home flaps failed had undergone single debridement only before flap transfer. The vessels, including radial and ulnar artery, were patent proximally. All 3 flaps were transferred between 2 to 8 days post-injury. Earliest free flap was done 2 days after debridement, in which flap necrosed. 3 flaps which survived were transferred after 2 weeks of injury. And the pedicled flaps which were performed included 2 groin flaps, 1 bipedicled abdominal flap, and 5 thoracoumbilical flaps. Functional assessment of gross hand function was done at 6 weeks, 2 months, 3 months, 6-month follow-up. Patients were provided with activities of daily living charts. The ADL score in all 16 patients was between 3 to 5. There was no progression and there was no improvement in scores at 3 and 6-month follow-up. So discussion is, most common victims of electrical injury were young adult males affecting dominant limb, mostly occurring at the workplace. Fasciotomy performed within 48 hours of injury with slightest evidence of compartment syndrome was found to be limb saving. There was a direct correlation between the point of entry of the current and the resulting neurological injury. The clinical and PET assessment of deeper soft tissue involvement showed that injury affected periosseous tissues more than superficial muscles and skin. Electrical injuries were progressive in nature and required multiple radical debridements until the wound is ready for definitive cover. The phenomenon of ongoing necrosis was not halted in this study, and their all early flaps failed to ingress the blood flow, so-called ischemic post-zone post-trauma. And distant pedicle flaps offered available and safe option for early coverage of hand and forearm defects in presence of recipient vessel injury. Two patients had myoglobinuria, one of whom required hemodialysis. Both patients showed improvement in their renal functions after debridement. Thus, it was observed that low urine output and persistent acidosis is indication for exploration and debridement rather than conservative management of myoglobinuria. 38 patients had injury to ulnar nerve, 12.5% patients to median nerve. Combined median and ulnar nerve injury was seen in 19 patients, but no involvement of radial nerve because predominant involvement of volar forearm in the patients. The findings at debridement correlated well with PET findings, and investigation aided the surgeon during debridement. Average duration of stay in the hospital was 61 days, and it was directly related to the number of procedures patient required for definitive wound cover. 6 patients returned to work after average of 98 days post-injury. One patient was electrician who changed his job, and none of the patient with bilateral involvement returned to work. Conclusion: high tension electrical burns represent a severe injury with significant morbidity, and the time tested concepts of early fasciotomy followed by repeated debridement remains the procedure of choice. The ideal timing of free flap coverage for these wounds needs further investigation. The limitations of the study was there were less number of patients were included in the study. When was the pedicle flap cover given to the defect after debridement? It is not mentioned. And what was the status of the pedicle flaps in the post-operative period? It was not mentioned. Thank you.
Dr. Eden, can you summarize what was the gist of this?
So the gist was that the to explore the effectiveness to start with an early wound debridement and then to provide the vascularized covering to the affected tissues in case of high tension electrical burns of the limbs. They have selected only forearm defects. In this study, only volar forearm defects were selected.
Rest excluded.
They have excluded, otherwise 81 patients presented with electrical burn, but only 16 patients fulfilled the inclusion criteria. All others who had severe head injury, spinal cord injury, or who presented with the charred limb, it was excluded. Those patients were excluded. And what they have seen is that the early flaps that were free flaps, the flaps which were performed early in the early stage, they have failed. And in the delayed stage, what they have done after 2 weeks, they have survived.
Maybe because of that, they are saying that it is a progressive process and the debridement needs to be done. Single debridement is not enough.
The serial debridements, they have given
Serial
importance to the
debridements are needed.
debridements.
Dr. Eidan, can I ask you a question?
Yes, ma'am.
Tell me, how do you define a high voltage injury?
Ma'am, high voltage injury is when the voltage of the current is more than 1000 volts. And the path of the current, it affects almost all tissues of the body. If the voltage of the current is less than 1000 volts, mostly there will be the contact burn.
So
It won't affect
majority,
the whole system.
okay. So all the patients in this study had high voltage
High
contact
voltage
burns?
electric burns. Yes, ma'am.
Okay, but it does not specify whether it was only the wrist which was involved or other parts of the upper limb were also involved.
Ma'am, they have mentioned that one patient had the involvement of the little finger also. It had to be debrided.
Okay, so where was the area of contact in all these burns is not mentioned in this
Is
study,
not
right?
mentioned. Yes, ma'am, it is not
We are
mentioned.
assuming that the area which was involved was the area of the forearm, the wrist, or the elbow, or what?
Upper limb.
It is just mentioned upper limb, but they
Ma'am,
have
because
not
it is, as
mentioned.
it is mentioned in the paper, that majority of the patients were electricians. Majority of the
And it
patients
is
were
the
adult
volar aspect
males.
of the forearm and the wrist.
So why is it that do we usually see involvement of only the wrist? What is the
Actually,
pattern of the contact burn, Vidal, Dr. Eidan?
The contact burn, it can either be contact burn or it can be the arc burn. That it is also not mentioned in the paper whether there was only
Okay,
involvement
what
of
is
the.
the concept of the arc burn? What does that mean? What is
Ma'am,
the
arc burn is when
presentation
there is
like?
no direct contact with the electrical source. The electrical energy travels from an area of high resistance to area of low resistance.
Okay,
And the circuit gets completed when the air particles are ionized. So
okay,
there is the presence of normal skin between the two charred areas.
okay. So basically, what we generally see in the contact injury is the involvement of the hand, where the entry wound is there,
Hmm.
followed by another wound on the wrist.
Yes,
Then there
ma'am.
is a wound on the elbow. Then there is a
Hmm.
wound on the axilla. So
Yes, ma'am.
what is this called? What is this phenomenon? Why don't we see the intervening skin burnt? We see the burnt area, the skin involvement only
Because
in
there
these
is the
areas.
ma'am because the areas of more when there is more sweating and there is less resistance, it makes tissues the areas where there is more it makes there is it depends also on the resistance of the skin. So the moist skin will be more resistant, there will be more electrical burn.
Okay, so the current is going to flow from inside the arm or from outside the arm?
Ma'am, electric current has impact from the in it is flowing from the area of the contact burn, uh, from the contact point, but it also involves the damages also from the inside or the damages from the outside also, but it involves the nerves, the vessels. So there is the formation of microthrombi and it involves
No,
and
that
the
is
neural
okay. That is
thrombus.
okay. Wait. I'm just asking you to explain the phenomenon of the skin burn only at these four areas. Okay, that is what is the most common thing which is seen, which is also called as an arcing of the burn, which you already
Arcing.
explained
Yes,
that
ma'am.
the
Arcing.
current flows from outside the body. Okay, so this happens because of the flexor, the contraction of the flexor muscles, and the current entering and exiting at these points. And it does have a relevance to the sweating of the skin in these flexure aspects of the joints, right?
Yes, ma'am.
So,
Yes,
how
ma'am.
is the fasciotomy, whether it is required or not? Because you mentioned that out of 16 patients, fasciotomy
Yes,
was done
ma'am.
only in 8 patients, right?
Yes, 9
9
patients.
patients, fasciotomy was done.
So
Yeah.
9 patients. What about the other patients? They did not require any
They did
fasciotomy.
not.
Then, if the
Ma'am, it is
fasciotomy,
mentioned in the paper that only 9 patients required fasciotomy.
okay, so that means in the other patients the fasciotomy was not required.
Ma'am, they have done clinical examination for the compartment syndrome. There is no use of any pressure measurement gauge. So they have assessed it clinically.
How did they? How do you measure clinically whether a
Fakat
fasciotomy is
ömrüm
required or
koptu.
not?
Ma'am,
Müthiş.
when there is tense brawny edema of forearm and
I
when
think
there is pain
someone's.
on passive
Excuse
stretch.
me, just a minute. I think someone is not muted. There is too
Yeah,
much
yeah.
of disturbance. Can I
Ibrahim
request
ayında
everybody to mute themselves,
mion
please?
patgai temperature में बात
Ma'am, when there is tense
not one
brawny
many
edema.
क्या नाम था जो इसका बैचमेट था सेकेंडरी
Dr.
डीएम
Rohit, you can't mute others?
ये चॉइस है तेरी मेरे लिए
1 minute,
No,
1
I
minute.
can't.
Dr.
Actually, the admin can only mute the others.
Yeah, whoever is the admin, please mute
Please
everybody
mute the
else
others. Please
except
mute
Dr.
the others.
Shetty.
1 minute,
Yeah.
sir. I will reclaim the host position and then I can mute these.
Okay.
Okay, sir, 1 minute.
Please.
Right. So carry on, Dr.
Yes, ma'am.
Eidan. Yeah.
Ma'am,
Okay.
ma'am, compartment syndrome is actually dependent on clinical suspicion and clinical examination. When we look at the limb and it has tense brawny edema of the forearm, and most important is that when there is pain on passive stretch of fingers, when there is paralysis and other features are like paresthesia, paralysis, pallor, and pulselessness. Pulselessness usually comes late.
So
But
paralysis, you don't look for paralysis,
yes,
right?
ma'am.
That is a wrong term. So you will look for a cold, clammy limb.
Cold clamp. Yes, ma'am.
Okay, pulselessness is a very late phase.
Late
So
phase.
initially you will see for a tense limb. And where
Tense
is
brawny edema.
and the tension is seen not only in the area of the burn but even proximal to that.
Okay, ma'am. Yes, ma'am.
Right?
Yes,
And
ma'am.
these people did a PET scan, PET FDG. What is that?
Ma'am, PET is positron emission tomography, fluorodeoxyglucose. Usually we see in normal cells, there is glucose uptake, and then glucose gets converted to glucose 6 phosphate and during metabolism of the glucose. But this is FDG avid glucose, which is taken up by the cell, and FDG avid glucose is not able to leave. It gets trapped in the cell. It is the technique which is used to look for metabolically active tumors or any cell in the body which is metabolically active. So if there is more uptake, there will be more FDG trapped within the cell. So we can see that. Like they have written in the paper that pronator quadratus was not viable. So the non-viable cell will not take up the FDG avid glucose, and it
Okay,
doesn't
so
get trapped in
when
the
is
cell.
this PET scan done? Which day they have done it?
Ma'am, they have done it after in the 46 to 96, 48 to 96 hours. In
Okay, so
6 patients, they
supposing
have done it.
they have done a PET scan, so that means
Hmm.
that is a very objective test and it should tell exactly which level the injury is extending to. So
Yes,
if it
ma'am.
is visible to us pre-operatively, then the debridement should be able to be done in a single stage. We should be able to say that, okay, these are the muscles which are affected by the electric burn and there is no flow in them. So then the debridement, actually speaking, because this test is not used routinely with every center, every unit, we
Yes,
generally
ma'am.
use it clinically. So is it a foolproof method to tell us that, okay, these are the areas which are dead and they have to be debrided?
Ma'am, in most of the patients, they have done on-table assessment of the tissues.
Okay.
But only in few patients, they have done the PET scan. And
It
on
was
the
not done
serial
on all.
No, ma'am, it was not done
Okay.
on.
It was not done in all.
Hmm.
Okay. Dr. Shetty, please.
May I intervene here? Actually,
Yes.
PET scan was done on the patient who had delayed,
Presented after delay.
presented delayed. They have done. The rest of the patients which they have debrided early and put the flap cover, this was done earlier. And these were the patients which presented in the delayed period. So they did the PET scan and they observed these findings that the quadratus was necrosed and they did the debridement accordingly.
Okay, Eidan, why would the pronator quadratus be involved if it happens that superficially we find that the muscles are normal, but if
Yes,
you
ma'am.
go in deep or like if
Ma'am.
the PET is done, they see that the pronator quadratus is involved. What would be the reason for that?
Ma'am, because pronator quadratus is the muscle which is which is closer in contact with ulna and radius at the distal wrist. And in electrical burns, we see the phenomenon that is called tip of iceberg phenomenon. What we look at the skin is not what is underneath. So, ma'am, because there is the bone which has highest resistance, and there in case of electrical burn, there is more of periosseous damage. There is more damage inside, rather what we look from the top, what is visible to the skin.
So, how do you explain?
Ma'am, injury severity, ma'am, actually what happens in electrical burns is tissue damage is seen and due to the result and the heat generated along the tissues which are closest to the bone.
What is this
Injury,
called?
so this is called, sir, according to Ohm's
Theory.
law.
Theory.
Which is the organ or the tissue which has the maximum resistance to the electrical current?
A bone has the highest resistance.
And what else?
And there will be more heat will be generated there, and there will be more periosseous damage.
So the muscle is in the pronator quadratus is just next to the bone, so it
Next
gets
to the
damaged
bone.
due to the heat.
Heat
Whereas the
generated.
rest of the muscles, why do they get damaged? What is the sequence of the resistance in the various tissues to the electrical current? Different
Ma'am,
tissues.
first, ma'am, most in bone, then in fat, then tendon, then muscles, and then blood vessels and nerves.
So that means that least resistance is in the
Least resistance is in the nerves.
So nerves are least resistant. That means the maximum current is going to flow through the if the resistance is least in the nerves, the maximum current is going to flow through which tissue?
Nerves.
Yes.
Yes,
So it is
nerves.
the nerves, and
Ma'am,
then
because
it is followed
according
by
to
the
Ohm's
vessels.
law.
Yes, you're right. So another thing is that okay, Dr. Shetty can ask a few questions.
Yes, ma'am.
Yeah.
Aidan, there's one more. Am I audible?
Yes,
Yes, sir.
yes,
Yes,
sir.
sir.
You are.
Yeah. There is one more mechanism by which tissues are injured. What you talked about current flowing through tissues and resistance causing heat generation, that is one of the mechanisms of injury to tissues. There is one more mechanism also. What is that?
Sir, muscle necrosis, increase compartmental pressure.
Those are all secondary. The primary injury in an electrical burn is either due to the generation of heat because of resistance to flow of current. There is one more mechanism that is described in literature. So it is called electroporation, which
Yes,
means
sir. Cell membranes.
yes. So
Cell
because of the
membranes get
passage
injured.
of current, there is disruption of the direct cell membrane and cellular damage directly because of the electrical current.
Yes, sir.
Yeah. So this concept of progressive tissue necrosis, what does this article tell about this progressive tissue necrosis? Because it's a controversial topic. There are people who say there is progressive necrosis. There are people who say, no, there is no progressive necrosis. So does this article tell anything? What are your thoughts?
Yes, sir. This article, it is written there that the the flaps covers which were given early, they failed because of the ongoing necrosis due to microthrombi caused by the passage of electric current through small capillaries. So the circulation of the wound bed was not adequate to support the flap cover.
Yes. But
No, but what is the reason for this? This is what Dr. Shetty is asking as to why there is a progressive. Why should there be progressive necrosis?
Ma'am, because when muscle damage occurs, there is swelling within the compartment.
Like
The pressure increases and the muscle blood flow gets compromised. It causes progressive muscle necrosis and more muscle damage.
yeah,
So
so
how
what
is
happens?
it progressive? It should stop after some time. If you are doing a fasciotomy, it should stop. And after fasciotomy, you are doing first debridement, but then you say second debridement, again more tissue is necrosed. So that means the damage is progressive. It is going proximally. That is what it means. So why is that happening? This is the question.
Ma'am, because of the formation of mural thrombus, initially the vessels look patent. The bigger vessels in the proximal forearm, they look patent. But because of mural thrombi present, they also involve the larger vessels of the limb.
So traditionally, the concept of progressive tissue necrosis came into being somewhere in the 60s or the 70s before the advent of microvascular flap covers and microsurgery. So the proponents of early flap cover, especially free flaps, they do say that there is nothing as such as progressive tissue necrosis. It's basically you are not able to do a complete and a thorough assessment of the amount of tissue damage. You said about the iceberg phenomenon.
Yes.
So there are articles which refute this concept of progressive tissue necrosis, and they say that it was already there, but you didn't know it.
Yeah.
Compartment syndrome is the effect of significant vascular damage and muscular damage causing raise in pressure.
I agree with Dr. Shetty. It is very important to assess the amount of damage primarily in the first debridement phase. And you should be able to see that the dead tissue is removed. If it is not removed, then obviously in the next phase of debridement, you will find that it is dead.
Yes.
Okay, ma'am.
But there is some difference in the debridements which we are doing in other types of traumas, maybe road traffic and others. And the debridement we are doing in this electrical burn.
See, I'll tell you, we raised the question of pronator quadratus. Many a times when you start doing the debridement, it is a full thickness burn. So you debride the skin. You debride the skin, you find that maybe the tendons are normal and you leave it at that and put a flap cover. But what actually happens is that the deeper muscle is also damaged. It is already dead and it has not been removed. So what happens, whatever flap you put, it will continue to discharge pus and all, because that necrotic tissue, if you leave, it has to get removed. So that continues to discharge the pus if the debridement is not adequate in the first stage.
So you are saying that you rule out that there is something occurring at the micro level.
Not micro. See what you are doing. They have done a PET scan. We don't even do a PET scan. We
Not
do it by
usually.
clinical. It is
Yeah,
done
yeah.
by clinical assessment only, whether the muscle is viable or it is non-viable. There are, as she mentioned, Vidal mentioned, you see the color, you see the bleeding, you see the contractility of the muscle, and you have to debride all that dead tissue. The earlier you do the fasciotomy, the lesser the progress of the damage later on or at the time of debridement. So that is usually limited if fasciotomy has been done timely. Otherwise, whatever effect is there because of the compartment syndrome has already happened and that muscle is already dead. So that is not going to progress if fasciotomy and the pressure has been released. Whatever damage has happened with the current
But
also has happened at the time of the current passage, and it is going to cause damage mainly to which vessel, Vidal? The vein or the artery?
But my
Artery, ma'am.
point is that we are doing day in and that there must be some difference, because whenever you debride any norm, any tissue, or and you debride a forearm or whatever of the electrical burn, and if you leave it as such that you have debrided, you have seen all the compartments, you have seen the deeper tissue, they seem to be viable. There may be contractly on touching with the cautery also, but the next day or the day after when you come again, the area which was red and which was bleeding day before, but it is not bleeding. So there must be some difference in the what the debridement, because debridement, the same person is doing debridement there also, he is doing debridement here also. There must be some difference
Yes,
in the two.
that is the reason, because in electrical burns it is the veins which are damaged more compared to the arteries. Because in the veins the pressure or the flow speed of the blood is less, so the concentration of the current at any point of time is more in the vein compared to the artery. So artery need not be affected initially. The artery may be normal, but it is the vein where the damage has started occurring initially. So if there is a problem with the venous drainage, then later on the muscles may show necrosis later on if you don't give an alternative route for the passage of the venous blood. That is why we say that if you do an early debridement and you give a distant flap cover, that helps in allowing some amount of venous drainage to happen from that area. You're not only providing the vascularity, because if the artery is okay, then vascularity is there, but it is the venous drainage which is affected. So if you can allow some way in which the venous blood can be drained, then that progression, which so-called progression that we say, can be limited. Dr. Shetty, your views on that?
Yes. I definitely agree with your comments. So we've also seen a lot of edema that develops in the affected part, that's affected limb. And we usually wait for some time for this edema to subside. Of late, what we are doing is we do the emergency fasciotomy on an emergency basis. We take up for a thorough surgical debridement of all the necrotic areas 24 to 48 hours later. And we always defer flap cover for about a week. We usually apply vacuum dressing on the exposed areas. This has actually helped us to maintain sterility, reduce infections, take care of discharges coming from the wound. So we generally don't do flap covers in the first week of an electrical burn. We do it a week later. We are able to hold on to the wound with vac for about a week most of the time.
Almost the similar. If you go to the paper also, they initially they had made the same assumption.
Correct.
Actually, their early coverage of the wound was that we are giving some vascular tissue to the area,
Correct.
so that it may get some vascularity from the tissue which you are putting over it.
Correct. Correct. Correct.
But they are arguing that it didn't succeed in their study. All the early flaps they did 3 flaps, and they all failed. And they came up with the idea that the wound was evolving. Actually, necrosis was going on, and over evolving necrosis, or what is called a progressive necrosis, they had put a vascular flap, but it could not survive because the necrosis was going on and it did not take up.
Correct.
Yeah, that is.
No,
So you are
my
saying that delayed flap is a better choice than going for an early flap.
see, I would say that my experience with early flap, we have done flaps within 5 days also. But if we do a good debridement of the dead tissue and we give a distant pedicle flap, I will not say a free flap, but a distant pedicle flap, it helps in,
Thoracoumbilical groin like.
Correct.
yes, groin or abdominal flap or TFL, then it helps in reducing the edema, it helps in the venous drainage also. But the main reason for even the free flaps failing in the initial phases is because of the venous thrombosis, not because of the arterial. Mainly it is the venous thrombosis because the veins are affected more. That is why the pedicle flaps are safer for this in the initial period compared to the free flaps being done the initial period. Secondly, if you do an early debridement and you leave the wound open, there is a very high chance of blowout from the radial and the ulnar vessel which is left exposed. Because if you are doing a thorough debridement, majority of the cases the radial and the ulnar artery is left exposed. So if you leave it exposed for a week, 10 days, there is bound to be blowout from these vessels. That is why an early flap in that case would be a better option.
True. True. True.
I too.
We have seen that if we leave the wound exposed for another debridement and we delay it for 10 days or so, there is a very high chance of blowing the vessels because they don't have a cover over them.
Yes, I do agree with Dr. Sujata. We too do the debridement and give the distant pedicle flap cover. I rarely see any blowout now. Earlier in initial days, we used to see the blowout, and I had seen only the maybe loss of dehiscence of the inside area, but otherwise the flap loss and all is not there if the early debridement and flap cover done with the pedicle flaps, distant flaps. So in this paper also, they haven't mentioned anything regarding the pedicle flap when it was covered with pedicle flap and what is the any complications came across with the pedicle flap. That is also one thing.
Limitation.
Yes,
Correct.
limitation
Correct.
of
Correct.
this article.
Correct. So,
And what about doing assessment of the vessels before doing a free flap?
yes. Yes.
That is
Yes,
also not mentioned in this article, whether
yes.
that was done by an angiography was done or not.
No, they have not done. They have done only in these patients they have done this PET scan. Rest they
Which
have
is
done
which
everything
is only
clinically.
for the depth of the damage, I believe.
Yeah.
Actually,
This
angiography does not is not recommended as a means to assess suitability of a recipient vessel. So most of the people who have done early free flap coverage have suggested that intraoperative assessment of the recipient vessel under the microscope is the best way to decide whether a vessel is suitable. So there are things like the size of the vessel and the pulsatility and the persistent flow in the vessel, which are important parameters. These are for the artery, and similarly, the backflow from the vein and the loss of resistance when you plug the veins. These are some of the features which actually are important for us to decide whether the artery and vein are suitable for a free flap.
Another thing they did not mention is that the free flaps which they lost was because of the venous problem or the arterial problem.
It is not mentioned. They have just mentioned
Not
they
mentioned.
failed. It is not mentioned.
Yeah.
The
So I
cause for
believe
the
that
loss of flap is not mentioned. Yes.
that is also not mentioned, because we believe that the reason for the failure of the flap would be more likely to be the venous thrombosis, because there is an intimal damage to the vessels by the current passage. There is no doubt about it. So once the damage is there, depending on the extent of the damage, it is possible that the microthrombi and these problems happen, and that is why the flaps fail.
Yes. So we also choose the recipient vessels a little away from the zone. So in electrical burns, we
Proximally.
typically go quite a distance, about at least 6 to 7 centimeters away from the
Yeah.
actual defect.
Proximal.
So your fasciotomy is not just therapeutic, it's also diagnostic, in the sense that if you have done it properly and released all the compartments, you know where exactly is the muscle damage, which is the proximal most extent of the muscle damage. So if your fasciotomy is, should extend up to the forearm, and if required, even beyond the elbow also. So it is not just therapeutic, it is also diagnostic, which will give you ideas as to the extent of tissue damage that is there.
Absolutely, absolutely.
That's
So, Dr. Eidan, how do you do the fasciotomy? What are the prerequisites?
Ma'am, first of all, we have to diagnose, we have to do the on the basis of clinical suspicion and clinical awareness, we diagnose whether we have to, whether there is compartment syndrome or not. Then the incision for the release of compartment pressure,
Will you go to the incision right away as soon as the patient has come to you in the
no,
casualty?
ma'am. No, ma'am.
Then what else will you see before you take up the patient for fasciotomy?
Ma'am, we will look whether there is tense brawny edema of the forearm.
Agreed. Your patient comes to you and he has established there is edema, there is a tension in the area. So what will you do before you give the fasciotomy incision?
First of all,
As
we'll give
soon as the
us,
patient comes, will you give? As soon as the patient comes to you in the casualty, will you give the releasing incision?
ma'am, first of all, we'll give
If
splint.
yes, why? If no, why?
First of all, we'll give splintage and keep the limb elevated. If there is decrease in pressure, if the edema settles, then we'll continue with splintage. But if there is progressing edema, then we will go with fasciotomy.
Okay, Idan, when the patient is coming to you with electric burns, your concentration does not have to be only
No,
on the limb. There are some other things
yes,
that
ma'am.
you have to keep in mind before
Yes,
you
ma'am.
address the limb. So, what are those things that
Ma'am,
you will
first
do
priority
before?
in these electric burn patients is life. We have to look whether the patient has any cardiac arrhythmia. Then we'll do ECG. And we have to do all baseline investigations. We'll look for urea creatinine levels. We'll look.
Idan,
Mm.
you cannot go to the investigations right away. When the patient is coming to you, how are you going to manage the patient? You said you saw the limb, there is tension. Okay, agreed. But how are you going to manage your patient? You are not, you said arrhythmias, you'll do an ECG. But even before that, if arrhythmias are there, you can.
Resuscitation. Ma'am,
Yes, so
resuscitation.
talk
We'll
about
start a
resuscitation.
resuscitation.
Yes. Why
Yeah,
is that
ma'am.
important?
Ma'am, resuscitation is important, first of all, in case as there is also concealed damage. So we have, in case of electrical burn, so we have to give fluid.
Okay. It may be just a 1% burn over the wrist. Okay.
Yes,
It
ma'am.
may be only a contact burn in the hand and the finger, and you see a deep full thickness area on the wrist. Okay, and you find that okay, there is some amount of tension or more tension in the forearm. So what resuscitation procedure are you going to follow?
Ma'am, we
Or are
give,
you going to give the releasing incision right away? I have to save the limb and I have to give the releasing incision.
ma'am, if patient has no other associated injuries and I diagnose that the patient has compartment syndrome of the limb, then I will give incision. Then I'll give releasing incision.
What happens if you give the releasing incision as soon as the patient comes? Do you anticipate any complications? What happens when you give incision in a limb which is undergoing a compartment syndrome?
Ma'am, there are studies which say that even after doing fasciotomy, gangrene can progress in
What
case
What
is
of
about
electrical
line?
burn.
What about the other organs?
What is the
You will not
reperfusion?
start with
There
the
will be
basic resuscitation, ABC, you
resuscitation.
will not
We
start.
have to continue that. To prevent it, we have to continue
But you are not
resuscitation.
starting that, you are not continuing.
You have
So we
not
will
talked about fluid resuscitation. What is a reperfusion injury? In this, not even a reperfusion. What happens if you give a fasciotomy incision as soon as the patient comes and you have not resuscitated your patient? What can be the damage? We say it is more damaging. In what way is it more damaging? Okay, how do you resuscitate?
Ma'am, we resuscitate the patient according to the Parkland formula. But
If
in
it
case of
is
electrical burns, we have to keep an eye on urine output also, and we have to give higher we usually give ringer lactate, but we have to give it higher than the thermal burns
Idan,
of
Dr.
burns.
Idan, if there
Yes,
is
ma'am.
only a 1%
1%.
burn, contact electrical burn, the topic that you are discussing, generally is not very extensive. It is mainly 1% or 2% burn, maybe 5%. How will you calculate the fluid requirement as per the Parkland formula? It is what? What is the formula?
Ma'am, 4 multiplied by total burn surface area multiplied by
Okay,
weight.
so I say it is 2% burns. 4 into 2 into
Weight.
weight, 50
Weight of
kg
the
weight.
patient.
Okay, so
Half of the fluid is given in
how
first
much
aid
is
as
this? Vidhan, I'm asking you to
okay,
calculate. If
4
it is
and
4 ml
4%
per
into
kg per percentage, how much fluid is it? It is 2% contact electrical burn, high voltage electrical injury.
450. 450 ml, ma'am.
So is it
400 ml.
450?
400
50.
ml.
It is
400
400
ml.
ml.
400
So
ml.
you will resuscitate your patient with only 400 ml of fluid for a contact electrical burn. Is that sufficient?
Ma'am, we have to keep the urine output we have to measure.
What are
So
we doing clinically? What are we doing?
how much urine output do you want?
It will guide your infusion. Na? What is the urine
Yes,
output? What is your target? Urine output.
1.5 ml per kg per hour.
Why 1.5?
More
In
than,
thermal burn, what is the target?
ma'am, in electrical burns, it should be more than 1 ml per kg per hour in
How
electrical
much? More
burns.
than 1 can be 9 ml, it can be 10 ml, it can be 2
1.5
ml, it can be.
4 ml.
So
1.5 ml.
why do you need that 1.5 ml? It is about 2 ml minimum.
Ma'am,
Okay,
because there is
but why?
concealed damage in case of electrical burns.
Anything
It will
further
be
you want to flush
concealed
something?
damage. We are
And to
talking
flush out,
about forearm. We
ma'am,
are talking
also,
about fasciotomy.
hemochromogen urea to flush out hemochromogens to
Yes.
prevent rhabdomyolysis.
Yes.
Yes. So what do you want to do? Why do you want to maintain that amount of output?
But ma'am, also to alkalinize the urine
That is a
using sodium
secondary thing.
bicarbonate.
We are
This is
talking
the
about
secondary thing.
fluid requirement. Your fluid requirement, how you're calculating.
Ma'am, to prevent acute renal failure from
Yes.
occurring.
Yes,
Yes.
absolutely. So to
Renal
prevent
protection
acute
is
renal
most
failure,
important.
you want
ATN.
to.
We have to do hemochromogen urea. There should be flushing of all the hemochromogens.
That is also a secondary thing. Okay, first of all, you have to resuscitate your patient. And how you calculate your fluid is what we are asking you. You cannot possibly use the Parkland formula or Brooks formula to calculate fluid requirement in a case of electrical burn, right?
Yeah, ma'am.
Okay, because you just calculated it's about 400 ml. 400
400
ml
ml.
is not enough for such a patient because you said there is a hidden damage. Hidden damage means there is damage to the underlying muscles. So if the muscles are damaged, what is going to be released?
Myoglobin
Myoglobin
urea,
urea. Then there is damage to the RBC. So what is going to be released?
hemochromogen urea.
So all these hemochromogens and these myoglobins, what are they going to do?
Acute tubular necrosis, acute renal
They are
failure.
going to settle in the renal tubules.
Tubules,
Do
acute
you
tubular.
want that? No, you don't want that. So what can you do to prevent that? Now you come to that. To prevent that kind of ATN from happening and patient landing up with a acute renal failure, what can you do in an electric burn? What are the steps
Ma'am,
that
we can give a sodium bicarbonate.
along with that, only soda bicarb will help? You have to literally flush the kidneys,
Flush the
right?
kidney.
So you have to give extra fluid. And
Extra
for
fluid.
that, you have to monitor with your urine output.
Urine output.
Patient comes to you and you catheterize the patient. You will start an IV line. You'll catheterize the patient. Why? Because you want to see what is the output. What happens to the output in a case of contact electrical burns?
Ma'am, it decreases because there is a lot of fluid goes into the interstitial spaces.
Does that happen in case of electrical burn or thermal burn? We are talking about only 2% electrical burn. See, the main thing is electrical contact injury. Electrical contact injury is never very extensive. It is limited to small areas of the body. But the extent of damage is too much. Okay?
Yes, ma'am.
So, you want to flush the kidneys.
Flush
To
the
flush the kidneys, you have to give extra fluid.
diuresis, ma'am.
So,
Diuresis.
diuresis is required, right?
Right.
So, how will you ensure diuresis? Flap cover will come much
Flap cover.
later. If you are able to save the life of the patient, only then you will go on to the stage of a flap cover or debridement. But if you are not able to save the life of the patient
Ma'am,
in the
we can
first
give
48 hours,
furosemide.
you give furosemide. Furosemide is the treatment of choice for electrical burn injury. Can we talk to other this thing, or only Vidan can answer? Idan can
I
answer.
think we should now go to the questions in the they will raise a good discussion. Dr. Rohit, can you read some of the questions? There are very good questions. They will very good discussion will be raised.
Yes, please.
Yeah, so someone answered, I think, mannitol.
Mannitol.
Tanveer Ahmed. Okay.
Yeah, yeah.
So mannitol is to be given resuscitation of fluid. It is very important to resuscitate to get a urine output of minimum 2 ml per kg per hour. Okay, that is the minimum amount of urine output that you will get. Only then you can ensure that you are really flushing the kidney. And for that, you give mannitol, which is an osmotic diuretic. And along with that, Idan, what you said was alkalinization
of the urine.
soda bicarb. Okay, and if you give your fasciotomy incision before you have resuscitated your patient and ensure that the kidneys are getting flushed, your kidney tubules are going to get blocked by the hemochromogens. So that was the reason why I was asking you how you will assess your patient before you give the fasciotomy incision. Yes, please go on to the questions now.
Please, sir.
One of the questions is I don't know why Dr. Skanda Shamasundar sir is there at this meeting, but recently we had a discussion and he said that he does not even debride electrical burns. He just put in the flap and allow it to slough out on its own. And I asked, won't that affect your flap survival? He denied. Maybe some light be thrown on this.
No, I don't agree to the fact that you don't do debridement at all. So
that's the basic teaching.
If it is only bare bone, we don't debride exposed bone, discolored bone, unless it is obviously necrotic. Especially in scalp, we tend to manage the wound conservatively. We may burr off superficial cortex, but we don't do actual thorough debridement of a calvaneal bone when we are covering it with flaps. So as long as there is no infection, we have found that the vascularity of the free flap or the free flap will take care of whatever necrosis is there. If there is a lot of non-viable bone that is present underneath the flap, that will manifest as a sinus 3 to 4 weeks later, which will be debrided. So Apart
Same
from
here
bone, I don't
also.
think we should let necrotic muscle, necrotic fascia, necrotic other tissues to be kept in the wound. I don't think
Actually, it
that
is
would be.
against the basic principle of the surgery.
Yes, yes.
I also agree with you. Second thing, this is a question, direct question to you, sir.
Yes, sir.
If we add a vacuum dressing or possible necrosis to the pronator quadratus muscle, then the vacuum dressing won't improve the necrosis and may lead to further sloughing and potentially blockage of the vacuum dressing.
No, if your debridement is inadequate, your vacuum dressing is not going to help because whatever is undebrided will be sucked into the vacuum and it get blocked. So the first prerequisite has to be a thorough debridement. And as far as pronator quadratus muscle, if it is necrosed, it has to be debrided. If it is not necrosed, it will not slough out. We are a little cautious to apply vacuum when bare vessels are exposed because that can aggravate ischemia. So try to keep some amount of periadventitial tissue and fascia around the neurovascular pedicles. We don't bare them in the first debridement. So
Any
that is one.
experience of covering, sir, of by the collagen? Some people are using debriding, putting collagen, and then coming again for the next debridement.
We have used collagen. More than that, we have also used Integra and Matiderm in some places.
No, for temporary dressing for a day or two, then you will again debride.
Yeah, we do use it. We do use it, but we found that vacuum is much more better in our hands than collagen. We may not be able to hold on to the wound for a week with collagen. We may have to open the dressing, we may have to inspect it, and we may have to keep doing dressing changes. So not much of collagen per se for electrical burns with exposed tendons.
We have the experience of covering the wound with collagen and observe the underlying muscle necrosis and take for the second debridement. It is very useful if the wound needs repeated debridements. As you told, if bare exposed vessels and all, they also will be protected by these collagen dressings. At our
There is
center, we use it.
there is one more interesting question. Won't the pedicle flaps cause steel phenomenon, as they need vascularity from the surrounding? If at all they have to survive, and then only we can divide the flap. So instead of providing the vascularity to the tissue, isn't it taking vascularity from the surroundings? Sujata ma'am.
No, I don't agree with that because the flap is getting its supply from it's an axial pattern flap or a random pattern flap. It is getting its vascularity from there. You are leaving the flap on for 3 weeks. In the initial few days, it is going to allow some amount of venous drainage to happen from the recipient side. And later on, it's going to get its supply from the surrounding once the venous drainage is normal and the underlying vascular supply of the limb is saved, then there is no issue with that. We have
Lakshmi
done
madam.
pedicled flap even in limbs where the radial and the ulnar artery have been ligated or they are totally thrombosed. So the flaps survive even in those situations because of the collaterals getting developed.
Correct, correct.
So
Same
there is
experience
no
here
such
also.
thing.
Exactly.
And Dr. Lakshmi had answered already in the chat box this question.
Actually, the
Any
Steele syndrome is seen in free flaps,
microvascular?
not in the pedicle flaps, microvascular flaps.
My another question will be, how many times anybody among you have seen that we have debrided, we have covered the forearm, maybe the wrist, but we could not salvage the hand. Flap is there, maybe free flap or the pedicled flap. It is vascular, it is good, it has not necrosed, but the hand or the part of hand we could not salvage. How many times?
It has happened. I will
Yes, it
not
has
say it
happened.
doesn't happen, but it has happened despite giving a flap cover, early flap cover. That is why this debate keeps going on whether the damage is progressive or is it because of inadequate debridement. So
Yeah.
probably in that case, it is the intimal damage to the vessels which is progressing and which is producing the microthrombi and later on to a major thrombus which is going to not
Yeah, we
provide
can
enough
take this.
supply to the hand, and the hand is going to go.
We've
Yes.
had one instance of trying to salvage an elbow stump. So there was circumferential loss of skin, and most of the forearm muscles were necrosed. The insertion of the biceps and brachialis was intact, and clinical examination showed that biceps and brachialis were working. So we put in a free LD flap to circumferentially cover everything, but we realized that the bone and joint vascularity was not there. So whatever is avascular, an avascular joint cannot be salvaged by any procedure. So we eventually realized that the whole whatever proximal stump of radius and ulna and the distal end of the humerus had just sloughed off. So it was lying loose. The joint integrity was lost in about 3 weeks' time. So
I have also seen a few cases like that. We'll come to this thing. Shova, madam. Madam, are you here? If you can unmute yourself, she has asked alkalization is no more recommended. This needs to be confirmed. If Shobha ma'am can join us.
The alkalinization has a definite role because it is supposed to increase the solubility of the pigments. That is the only role of alkalinizing the urine. And I don't think that it is in controversy that you should not alkalinize. It helps in reducing these, increasing the solubility of the pigments so that their precipitation is less. That is the
What is,
only role of alkalinizing the urine.
let us hear to ma'am. Ma'am, are you there?
She is in participants, but
You can
You can
unmute
unmute.
her.
She can unmute.
she can unmute.
Till she is she here?
No.
Okay. Though the debridement with distant pedicled flap cover is preferable to microvascular tissue in limb salvage whenever possible. Which is preferable? Very debatable question.
it's
What
a very
will you
debatable
prefer?
question. Who
Yeah.
There are people, it also depends on the operating surgeon's decision making. So as long as the decision making is correct, which includes thorough debridement and thorough assessment, you have to thoroughly assess the entire limb as far as the skin and the neurovascular status and the muscle and tendons. So beyond that, if you are comfortable doing a microvascular procedure, and if you are sure about the recipient vessels, if you are sure that whatever vessels you choose are good enough, it does help. If it's a microvascular procedure, it's a single stage procedure. The limb is not bound to the trunk, as in case of a distant pedicle flap cover. And it does reduce the amount of hospitalization if we do a microvascular flap cover. If it is an isolated wrist or forearm injuries, we are able to send home the patient back in 2 weeks' time. There is no need for additional debridements. Mobilizing the limb becomes easier. So there are a lot of advantages of a microvascular procedure also. But at the end of the day, it's a choice which the treating plastic surgeon has to take. That is my take on this.
Dr. Shetty, will you also tell whether the free flap, if you're doing a free flap cover, what would be the ideal time? Would it be in the early phase or would it be in the intermediate phase?
In our institution, we generally avoid doing a free flap in the first week. So what we have noticed is that immediately after a fasciotomy, there is some amount of perfusion that goes on into the limb. This leads to a significant edema, and all your tissues are swollen, and you have not done a debridement. So when you go back to do a debridement, you have to be extra careful. You are also looking at resuscitation. You're also looking at other aspects. If it's a major burn, there are other issues to be taken care of. So we generally don't do free flaps in the first week. The earliest that we do is usually in the second week. If our debridement gets delayed, we generally go on to a week beyond that also.
And I believe that majority of the people who have tried doing a free flap in the early first week
Correct.
have a high failure rate.
Yeah.
There is a
Same in
100% failure rate.
many papers. Same in many papers.
Yeah.
Yes.
Something you can add. There is question about the fluid resuscitation and the role of can we continue with the RL? Some people are saying that we should not continue with the RL in the resuscitation. Or is there any formula like 7 ml per kg, or it is strictly according to the urine output?
No, it has to be there. See, some people, we say that when we calculate the amount of fluid, it comes out to about 5 to 7 ml per kg per hour.
Correct.
That is what we have found, but we never calculate fluid as per 5 to 7 ml per kg per hour. We have to just start the fluid and we have to monitor as per the urine output. And if despite giving fluid output is not coming, then CVP line needs to be put in, because otherwise you can overload the patient also.
Yes.
Is Dr. Pramod sir here? Pramod Kumar sir. He has a lot of experience with this limited access.
Yes.
Yes, sir. Good evening, sir.
Hello.
Yes, sir. You have put a better to use limited access dressing. Please, can you elaborate on this, especially in the electoral burns?
Yeah, limited. Yeah, it is very important because what we do is thorough debridement and fasciotomy, proper fasciotomy, releasing superficial and deeper compartment, and then apply land and leave it for some time, 1 week. It is intermittent negative pressure in limited access dressing. That will prevent the edema also, because intermittent pressure will compress the tissues and edema will be reduced, and it really reduces the secondary damage to the tissues. And after 1 week, we can every day we can see through the transparent dressing what is going on inside. If something
Can
goes
you
wrong,
explain?
we
Sorry,
immediately
can you
remove
explain
and
for
do
the
second
juniors?
debridement and apply another lad. And then
Actually,
what happens?
I pardon, sir. Actually, maybe
Hello?
some juniors are not
Cannot
understanding
hear.
what is. There was,
There's
yes, sir.
problem sound.
How are you doing this? For the
Hello?
sake of
Pramod Kumar
juniors?
sir. Pramod Kumar
Yes.
sir, if you have some
I can't
pictures,
hear.
better to project pictures if you
Yeah.
have.
Because you have a lot of experience with this limited access
Hello?
dressing.
Yeah.
You are putting that in a
Yeah, I
transparent.
can't hear. Some problem in there. Sound.
Can you please
Okay.
explain the
Hello?
limited access dressing, what you are doing, sir?
Yes, sir.
Can you please explain
Hello?
in detail?
I think there is
Hello?
some network issue.
Sir may have some network issue.
Yes, yes.
We
yes.
can complete later
Yeah,
on.
some.
Yeah, yeah.
Okay.
Actually, it is a very good dressing. Sir is a lot of work, done a lot of work on this. Maybe sir is also out as Ratnam sir. Maybe there is some network problem there.
So, can I ask Aiden?
Yes, sir. Yes, please.
Yes, sir.
Choice of flap. Did you touch on that topic of choice of flap cover? What does the article say, and what is the recommendation? How do you decide choice of flap?
So they have written here that the pedicled flaps are better. Yes, in case when there is vessel injury, so they
Okay.
have chosen pedicled flaps for that.
Okay.
And if the patient is unstable, they have chosen
Okay.
pedicled flaps for that.
So regarding
And
the
if
type of tissues in the flap, we have different types of flaps. What type of flap is suitable for a area like a forearm, and why is it?
sir, you're asking about pedicled flap or
That
free
is
flap?
the vascularity and the design of the flap. This is the tissue composition of the flap, which I'm asking.
There are muscular, fasciocutaneous.
Yes. Do you do a fasciocutaneous flap? Do you do a skin flap? Do you do a muscle flap? Do you do a facial flap?
So,
How do you decide?
in pedicled flaps, mostly groin flaps are done.
Yeah. So what is the thought process? Why is a skin flap? See, broadly, when you say tissue composition, we are using skin flaps. It may be either only a direct skin flap, or it could be a fasciocutaneous flap, or you do myocutaneous flaps where muscle is also included, or you do only a muscle flap. So how do you decide which flap to choose as far as the tissue composition of the flap is concerned? When do you decide to do a skin flap or a fasciocutaneous flap? When do you decide to do a muscle flap? In the forearm, what is the flap that is usually preferred? Any thoughts on that?
If the defect is exposed up to the level of the bone, then we will go for muscle flaps.
Okay.
Mm.
See, what you need to understand here in a forearm defect in electrical burns is that you are looking at exposed tendons, exposed vessels,
Tendons
maybe
also.
exposed bone. One is exposure of structures which cannot take up a graft. So that is one indication for the flap. The second is you are trying to salvage those tissues. And the third reason why you're doing a flap is to enable subsequent procedures. So when you have to do subsequent procedures,
Secondary
especially with
procedures.
respect to tendons,
Mm.
a skin flap is probably a better choice than a muscle flap because the muscle is going to adhere to whatever bed that is there. So if there is a significant element of infection that is present, if there is a cavitatory defect, if there are deep spaces that need to be plugged, those are the situations where you'd prefer to do a muscle flap. In journal literature, if you see, facial flaps are actually very good if you're only going to cover the tendon which is actually intact and it is functioning. So facial flap will be very thin and it allows some amount of pliability. Skin flap is always the preferred choice in our because most of these patients usually have nerve palsies. They do develop claw deformities. They do develop these things which need secondary corrections. They may need tendon reconstructions. So it's easier if we have a skin flap or a fasciocutaneous flap that's in place to facilitate subsequent procedures.
I agree with you, Dr. Shetty. We also prefer skin flaps because we have to do tendon reconstruction, nerve graft, cable grafts later on, secondary procedures for patients who've lost their tendons. And invariably, they have median and ulnar nerve injury also. And muscle, I would say, would be better if free functioning muscle transfer is done for reconstructive purposes later on. And for that also, skin flap will be good.
Correct. So if a free functioning muscle transfer is planned in case there's a extensive loss of all the flexor tendons and muscles. So in such situations, we avoid a free flap for covering the wound. We prefer to do a pediphyseal flap cover so that you preserve the recipient vessels for a subsequent free functioning muscle transfer. So a lot of thought process has to go into how exactly are you going to start the process of improving the wound, healing the wound, covering the wound, and subsequently rehabilitation. Unless you think about this in a systematic way, you may have to change your subsequent reconstruction plans.
Agreed.
Agreed. Anyone from the attendees who want to join the discussion, please, you can unmute and your comments, queries. Please feel free to join us. Shobha ma'am.
This is Shubha Chamaniam.
Good evening, ma'am. Good evening.
Good evening, ma'am.
Yes, so I had mentioned I use a lot of alkalization and was very impressed with its effects of clearing the myoglobinuria was gone very quickly. But recently, I have come across some literature saying that this is no more the standard guideline to be recommended. And I forget where have I read it, but maybe I can go and look at it and get back to you.
Yes, ma'am. I would love.
Sure, ma'am.
I would love it
Yes,
if you
ma'am.
could share that article with us.
Yeah.
Because one has to do a study, comparative study with and without alkalinization to be able to say whether it is useful or not. And I have not come across any study which would.
So this is very recent, and I was pretty surprised as to why are they not alkalizing.
Yes.
But they were very categorical about it. I will let you know.
Thank you, ma'am.
Thank you.
Ma'am. Any comments?
The wounds of electrical burns always edematous and reluctant to take the skin graft as well as flaps so early when compared to the other wounds like flame burns or the trauma. So what is your take on the hyperbaric oxygen therapy in these wounds? Your experience, can you share? Any of your?
I have no experience of using hyperbaric oxygen therapy for electrical burns at all. And see, the basic difference for the inability of graft and flap to take up is in electrical burn is because of dead tissue remaining if it is inadequately debrided. And whether the HPOT therapy can improve the oxygen supply and salvage the dead muscles, I don't know.
Actually,
But
even
it would
after
improve.
repeated adequate debridement, the wound will be lot of shows the edema and inflammation. So,
Yes.
what type of dressings do you recommend in your institutes or in your protocol?
No, we do
Even
the.
go
Okay,
ahead, ma'am. Go
doctor.
ahead. Go ahead. Go
Yeah,
ahead.
yeah, please go ahead.
Even I don't have
Both of you.
experience with HBOT. We don't have the setup in our place. So we haven't used it in cases. And I think the ongoing damage is because of the microthrombi and myonecrosis and tissues in a deeper plane, which are yet to be debrided. So we do conventional dressings, but of late my preference is to put a vacuum onto the wound, which takes care of most of these things, as long as your debridement is adequate and thorough. So
Dr. Shetty, on which day you will recommend the VAC therapy? On the same after fasciotomy immediately you recommend?
no. We do the emergency fasciotomy on an emergency basis within 24 hours. We
Yeah.
usually take up for a thorough debridement after 24 to 48 hours, usually 48 to 72 hours later. And after the first debridement, we decide whether the debridement is adequate or not. If debridement is not adequate, we do conventional dressings and do a second look debridement after again 48 hours. And once we are thorough, once we are satisfied with the amount of debridement, we apply VAC on table. We don't apply it later on. We apply it on table, and we retain it for about a week, and then plan the flap cover.
Okay. So
Actually,
about
coming from
on
the
fifth day, you will recommend the VAC, and 15th after 15th day of flap cover.
Yeah.
So usually like that.
Usually.
actually coming from the wound conference today only, these are the most debated thing there. The role of HBOT and what was the cause, though the mechanism is not fully known. So it has been beneficial in everything. They are putting anything, any flap, any trauma, whatever, they have put even the Alzheimer's, they have put there, they have put all neurological, and all the
Yeah.
patients have shown some improvement.
Yes.
There are so varied indications. They were saying in the few 2-3 papers were there, and they were most debated. Actually, everybody has to be put in that chamber. I could infer from that only this thing.
Yeah.
Because
There,
there's
Yeah,
so much
there are
of less
lots
oxygen in the air because of so much of pollution.
yeah.
So you have to
They have
supplement
done.
it from outside.
They have even done urological thesis. They have put. Then there was improvement in the trabeculations and all that in the bladder. They have put some brain trauma patients. They have put some failing flaps. They have put some grafted patients and do the comparative study. Everything they have done. So it is a very good idea that it may be used in the electrical burns.
Yes. The
Yes.
Somesh from Chennai and Dr.
He's here.
Vishal Mago and Dr. Smita, they have done a study that
Anybody among them is here?
I
I
don't
don't
so
think.
I
Dr.
don't see.
Smita was there, I think.
I don't
She
know.
was there. She was there. Maybe she has left.
Maybe.
Bhattacharya, sir.
Sir has joined.
Yeah, sir is there. Good evening, sir.
Good evening, sir.
Good evening. I have joined long back.
Yes,
I
sir.
was
Sir was
enjoying
there.
the
Sir.
Wait.
I was enjoying the discussion and very interesting. If you want me to comment something,
Yes, sir. Yes, sir.
right. So actually, the whole crux of the problem of wound management in electrical injury vis-a-vis thermal injury is that it is a progressive wound and therefore repeated debride. It is the difficult part is that to identify early the area of demarcation, or how to assess the progress of the necrotic process. Now, I just want to highlight that I acquired this technique which is simple, but nowadays not much used, but is extremely useful. That's what I want to say. Is the fluorescence step.
Yes.
And if anyone wants to know in detail, we have published it in Indian Journal of Plastic Surgery quite some time back regarding the flap circulation, etc. But it is applicable for burn mostly, because Dr. Matangi started with burn and she used it extensively. So the details are there. What it is that when you inject this fluorescent dye, which is very, very cheap, you need an ultraviolet lamp and you visualize the limb. And you can visualize the limb repeatedly for 36 hours without further injection, because the dye get excreted through kidney in 36 hours. So you can repeatedly reassess whatever you assessed earlier, whether it was correct or not, and so on. So I think that fluorescence study, if it is done in routinely in burn cases, especially in electrical burn or any other burn, then you can easily demarcate more or less the area of which requires debridement, which is non-viable, and which is viable. I think that will reduce the number of repeated debridement procedure, and it will make the wound earlier for any type of cover, whether it's a free flap or pedicle flap. That's a different issue. But main problem with electrical burn is to how to assess and how to make the wound ready for cover. And I will strongly suggest all that is new is not good, and all that is good is not new. So, so fluorescence study, if you adapt, I think you all will be highly benefited. Try it and see the result. It's very cheap. Once you have a setup, you can repeatedly use it in all the patients.
Thank you, sir.
So if you want, you can just go through the IJPS, our publication. You will get all details of the procedure, how to do it, and what is the dose, and everything. So I would recommend, because the main thing is revolving around wound preparation and versus progressive necrosis. Whatever, all the pathophysiology we understand. The thrombotic phenomena, the tissue damage, the muscle damage, we understand it very well.
Right, sir.
But we are unable to still progress on how to do early detection and do minimum debridement and make the wound ready at the earliest. That is the crux of the problem. And sometimes, if you do a late cover, waiting for some area is ready and some area is not ready. It is still, devitalized.
This always happens.
So
Most of the time.
even the area which is vital structures are exposed, which are ready, waiting for the adjacent area to get ready, we lose that part also.
Yes.
Correct.
So
Correct.
that is why the number of debridement should be as early as possible and make it ready. And I think the fluorescence study will be extremely useful. And I think you should adapt, and then whether you feel it useful or you may discard it. I mean, this thought, but it's extremely useful, I'm telling you.
Thank you, sir. I will reiterate here for the residents. It is your platform. What is said of you, for you, by you. Presenter is yours. Please, you can ask the questions. You can put your comments, because this whole platform is for you only. We are also, I think, we are learning more than our residents and the junior colleagues, or whatever you call it. Please, any comments, any queries, please feel free to ask.
Just a question. Sorry.
I think chat box is.
We have finished with those. Now almost all are answered. I was checking that.
Yeah, they are all
Almost
answered.
all are answered there.
Did we address the thromboprophylaxis protocol for these patients?
No, we didn't went to that.
Yeah.
So if you're talking about venous thrombosis, would
Yes, ma'am.
thromboprophylaxis have any effect on this progression?
I think that's a very good question, but We, madam, have never used any antithrombotic agents for this in electrical burns.
Yes.
Neither low dose nor the regular heparin. One heparin because you need to do repeated debridements.
Debridements.
Then there'll be bleeding problems.
Correct.
And low molecular weight may be used, but I don't think I've read any article also on that.
No.
Whether that will.
No, even I don't remember reading any thromboprophylaxis being used specifically for preventing venous or arterial perfusion problems.
What is your take, ma'am, on this? Anything new?
For
what are you doing, ma'am, in your
Are you using, madam?
in your institution?
For thermal burns, we were using, and I was wondering if electrical burns also had similar thing.
No.
After fasciotomy, we are using the Clexane, madam, low molecular weight heparin. Definitely, because we follow the EDAF method of treatment. So early fasciotomy, early amputation, and debridement, and following that the distant flap cover. And I start using the Clexane. It is showing good result only, man. I haven't compared with without using the Clexane, but we are using at our center.
Any comments from the seniors? There are so many seniors here. Angelina Madam, Krishnamurthy sir, Dr. Farooq is there, Dr. Shabir is there. So many seniors are there. Any comments from?
I want to ask for the benefit of PGs,
Yes, ma'am,
if
yes.
the patient presents to us after 3 days of injury with edema of tense edema for the forearm, do you recommend fasciotomy, and what precautions to be taken? Late presentation with
Need of fasciotomy.
compartmental syndrome features.
See, if 3 days later patient is coming, it will first, we have to see probably the gangrene has already got established. 3 days is too long a time for the limb to be
No
salvaged if there is a.
established gangrene, but tense edema and these things rarely we come across this type. But if it crosses 3 days, do you recommend fasciotomy?
I would much rather first resuscitate the patient, see his urine output. If that is okay and all parameters are okay and there is no indication for fasciotomy, then avoid.
Actually, madam is saying
Judge.
compartment is tense.
No, if the compartment is tense, then you have
we
to
have
do
to
a
go for it.
fasciotomy.
We have to go for it. We have to go for
There
it.
is no other way. Then you have to go for it, and you have to give antibiotic cover and do a proper resuscitation. Maybe do a CPKMB and CK to see how much is the degree of damage, because 72 hours is a long time. It could be because of infection and not just.
Correct. So if it is usually 72 hours is not evolving compartment syndrome, it's usually an established compartment syndrome. So if the vascularity is very critical, you may have to address that. Very rarely have we've never done that. So usually if the vascularity is very critical, we end up amputating the limb. And if the vascularity is not critical, then we look at if there is tenseness in the compartment, we do release. As I said, fasciotomy is not just therapeutic; it's also diagnostic. So the primary aim in those cases is doing the debridement. It is better to do the debridement before established infection, local infection, sepsis sets in the wound. So we target do primary formal debridement instead of just doing a fasciotomy. We do a formal thorough debridement of the wound as the first go in such delayed presentations, as long as the systemic factors are taken care of well.
For the PGs coming to the fasciotomy, I want to highlight what about the nerve compartments?
Yes, the carpal tunnel and the Guyon's canal should be open to reduce the damage to the median nerve.
It's a message for our juniors, because most of the fasciotomies
carpal tunnel has to be open.
Are done in the emergency by the residents only. So these tunnels ought to be opened. That's the very vital thing.
Yes, yes.
Not only you have to open the skin only.
We
Skin
generally
fascia.
open the carpal tunnel
Carpal
in every
tunnel.
case where we do a fasciotomy of the forearm.
And in fact, if the fasciotomy is done for the forearm and the hand is tense, then we have to do a dorsal compartment
Right.
also for the intrinsic.
Even the digits also we do.
Yes.
Digits and thumb we do. Anything more?
One more
Anybody wants to
question.
add?
What about increased risk of reperfusion injury in delayed fasciotomy in a compartment syndrome?
That risk will be there if the gangrene has got established and we just open it up, it's going to lead to ATN immediately.
Yes.
That will be there.
So we do it under tourniquet and whatever, if it is gangrenous, we debride everything. So systemic reperfusion is not so much of a serious problem. Yeah.
If it is established gangrene, then no.
Yeah.
Then it cannot be. And the answer is the resuscitation, fluid therapy.
Yes.
That is very important.
Yes.
Systemic fluid therapy and followed by the
Yeah, and
fasciotomy
close
and
monitoring about the
debridement.
urine output.
Yes. So
That is important.
always it has to be recommended and look the underlying tissue and go for the debridement. So never to hesitate to give the fasciotomy.
Yeah.
In electrical.
We should have a very low threshold for the fasciotomies actually.
Yeah.
Can I have some input?
Yes, sir, please.
Yes, sir, please.
Limited access dressing was just touched and left, and
yes, Dr. Pramod is expert in that. Yeah.
Yeah, Pramod Kumar has left because of the connectivity problem.
Yes.
But I have sufficient experience, and I got trained by him.
Yes,
and the limited access dressing. I think it is appropriate to introduce that here because many people, especially juniors, are not exposed to it.
That's why
it
I
is,
asked.
yes, it is. Done in the department itself. We don't have to go for KCI and those vacuum suction, etc. They are not necessary. In the department itself, it can be done. Professor Pramod Kumar has demonstrated in several national and meetings. Yeah, those videos are also available on the internet, and his publications, more than 10 publications are there. His publications are available both in Journal of Society for Wound Care and Research. It was established by him only, but now it is rampant. Throughout India, it is available. Every year, annual sessions are being done. So it's journal. He has got so many publications, and others who are doing also, like Dr. Ravi Chittoria of Jipmer and all, they also published their experience on that. All these are available, and video demonstrations are also available. The advantage of it is you can see the wound progress directly, and it removes the edema as and when it comes. And once in 5 days or once in 4 days, you can take to theater, and the necrotic tissue comes as something like a piece of chalk in water. Just you can with thumbs you can remove that necrotic water and put it back. Put the not the material. Put the lead back, and then wait for a few days. It avoids infection, and it draws the fluid, inflammatory fluid, and the products of inflammation also, and it helps. And at appropriate time, you can put skin graft. That's enough. So this sort of repeated debridements are probably minimized, if at all. So this I want to introduce. The readers or juniors can get them on the internet in this journals, as well as the videos also on YouTube. They are available. That is limited access dressing by Professor Pramod Kumar.
Actually, you can always continuously monitor the dressing because it is a transparent thing. Yes, we have also tried it a few times. I have also done in a few very good. It has a very good results, and it is quite transparent bag or whatever you call it. You can devise of your own is there, and results are very good. And I request all of the juniors as to please go through those papers, and what sir is saying, videos are also available. Please go through that. You will be benefited definitely.
It is very effective and inexpensive.
Sir, there is one more question in the chat box.
Please, please.
If gangrene is set, it's better to do amputation first at the level of gangrene and only do decompression of proximal areas like arm. So whenever gangrene is set, you look at the demarcation of the skin. You don't have to debride skin proximal to the gangrenous area. But what you have to be liberal is to debride the fat, subcutaneous tissue, fascia, and muscles. So usually what we see is the amount of skin necrosis is less and the amount of muscle necrosis is more. So when you do an amputation for a gangrene, we try to debride almost all of the unhealthy and necrotic muscles much proximally. But we don't debride skin proximally. If we need access for proximal debridement, we incise the skin for this access. And we usually leave the amputation stump open. If the skin edges are approximatable, we do tacking. And we bring back the patient 48 to 72 hours later, or maybe a little later on, for formal closure of the stump.
Yes, sir.